welcome to everyone. This is the AONM Academy of Nutritional Medicine, first of the year actually, webinar with Professor Jack Lambert. We're delighted and very honored to have him to talk to us today about long COVID from a clinical perspective. I'll just introduce him briefly. He's an infectious diseases consultant at the MMUH and a professor at UCD School of Medicine with over 25 years of experience working in HIV, hepatitis C, STIs, and other disease areas. He trained in the USA and the UK and worked for 6 years in Baltimore at the Johns Hopkins Institutes and the University of Maryland Institute of Human Virology, where he developed skills in vaccinology, HIV, and international health. Professor Lambert holds consultant specialty certifications in adult and pediatric infectious diseases, general medicine, and sexual health. As a lead of the International Isolation Unit of Ireland from 2010 to 2018, he's managed all emerging infections, including Ireland's Ebola effort, and has taken a clinical lead at the MMUH on the management of COVID-19. He's led 𝐏𝐇𝐈𝐒 Europe, a €1.8 million project aimed at improving the elimination of hepatitis C in the European Union and co-funded by the European Third Health Programme. And most recently, he's been in receipt of a Health Research Board grant for long COVID and has published his experience in managing patients from the long COVID clinic at the Mater. So we'll be listening to Professor Lambert for around 45 minutes and then have time for questions at the end. Please put them in either the chat or Q&A, and over to you, Professor Lambert. Thank you so much.
Okay, so thank you. Let me just see if I can share screen. Okay, so welcome everybody. So the title tonight is Long COVID from a Clinical Perspective, and I will be throwing in just some of the challenges of COVID and some of the politics of COVID as well from an Irish perspective. I know the people on the call tonight are both UK and Ireland, but I think some similar issues are going on elsewhere, not just in Ireland, but there's issues throughout in terms of service provision for long COVID. So the definition long COVID was first described by a doctor, and it was published actually in Lancet. It was, and he got COVID himself, and he described the terms, and most people use the definition sick for 3 months post your initial COVID-19 infection, and that's kind of the definition that I use. This is kind of one of the first studies we did at the Mater back in 2020, and published actually quite shortly thereafter. And these were just the first 100 patients admitted. And if you look at the symptoms, they presented with acutely cough, fever, shortness of breath. These are respiratory things, but also if you look, fatigue, myalgia, sore throat, headache, nausea, a lot, their central nervous system things, and then nausea, diarrhea, abdominal pain, those are gastrointestinal things. And then moving down, you look at loss of smell and taste. Those are the nerves coming out of the brain, cranial nerve 1 and 2. So we knew early on that COVID was not just a virus that attacked the lungs, it attacked the body and attacked the brain as well. So as stated, I realized back in April, having seen patients early on in March, that that COVID wasn't going to go away. If you looked at the reports coming out of China, they had people sick 4, 5, 6 months. And if you look at MERS and SARS, patients were sick for years and years following MERS and SARS. So I applied for funding through the Irish Research Bureau and was given 200,000, and we established a cohort of patients, but also set up a clinic to provide clinical care for patients. And most of those patients then were the first wave, and a lot of them were the staff from the Mater Hospital and from other outlying hospitals who were infected in the first wave of the pandemic. And this is one of the first questionnaires that we did. The SF 12 questionnaire assessing the impact of COVID-19 in 1 year. And I have a graduate student who's doing his PhD, MD thesis, Brendan O'Kelly, an infectious disease consultant now. And he's the one that put all this data together. And basically we did questionnaires, a baseline and a follow-up using both a physical component and a mental component. And I'm just presenting one slide here from all the data. And basically, if you look at 12 months, if you look at 3 months and then look at 12 months, people are still not well. 10% of patients in our cohort were still sick with physical symptoms related to COVID, long COVID. And other studies have reproduced this. And in fact, it can be up to 30%. So there's a wide variety. But not everybody recovers from COVID. And people say that 10 to 30% of people are still sick in 1 year in some capacity. Some of them are totally bedridden, a small percentage, I would say maybe 1%. And some are what I call the walking wounded, people who are going to work, but struggling, crashing when they came home, or going to work and not really functioning 100%, having brain fog, having problems with word finding. Like one of my colleagues, his boss says he's demented because he can't remember MD's name in the office. One of my colleagues, who's a professor of rheumatology, basically can't remember the name of the drugs when she's giving lectures at the university, and she's a year down the way. Now, she's fully functional in terms of going to work, but a lot of people are affected by COVID. And then this is another study that was done just looking at the neuropsychiatric effects of long COVID. And this was done in collaboration with our colleagues in general medicine, general practice, and Walter Cullen and his group. And we did an evaluation of these same patients and looked at their mental health at 1 year. And if you look then, 18% of people at 1 year had depression. And these were people that didn't have depression before. 13% had moderate to severe anxiety at 1 year. These are people that are never anxious. These were calm, cool, collected people that all of a sudden, having got COVID, they had this unexplained anxiety. Since a lot of the first wave were people who were in the hospital in the ICU, there was an element of PTSD, 21%. And then 70% of participants actually from our questionnaires reported concerning alcohol use. Now, this doesn't mean that they were drinking heavily. These are people that maybe never drank before who were turning to alcohol as a way of coping with the stress or coping with the symptoms. But there was an issue of these were issues, real issues that people were experiencing one year down the line. And this is something that we haven't published yet. This is one of my doctors this year. We did analysis of the patients who went up in the ICU and HTU, and and looked at 295 of them that ended up in the ICU, HTU. Interestingly, 22% of them died, and 29% of them were mechanical ventilation. This was the first wave. And we actually looked at viral reactivation in this group. So we looked at EBV reactivation. So these viruses that I'm discussing are herpes viruses. They're all herpes viruses, and herpes viruses are DNA viruses that once they go into your body, they stay there, and they should stay there dormant. But if you have AIDS or you have transplant, they can reactivate. Interestingly, in the ICU, they did PCRs on some of these patients, and 27 out of 295 were Epstein-Barr virus viremic, which is quite unusual. Like I said, you don't see that normally in normal patients. And Epstein-Barr has been, called the chronic fatigue virus. And why are they reactivating? We actually looked at lymphocyte counts, and unfortunately the numbers were small, but if you look at this graph there was a trend towards those who are Epstein-Barr virus positive having lower lymphocytes than those who are Epstein-Barr virus negative. And then when we looked at CMV viral reactivation, CMV is a virus that you only see in transplant patients, secondary CMV, reactivation CMV, or in AIDS patients. And interestingly, we saw, only 67 patients of the ICU patients were tested for CMV viremia, but a total of 15 were positive. Of those, 3 were actually transplant patients, but 6 were on ECMO, which, kind of a pump bypass because their lungs had given out. And 6 of them had no underlying risk factors prior to ending up getting COVID. And we also looked at the lymphocyte count, and there was a trend toward the lymphocyte counts being lower in the CMV positive than the CMV negative. And then finally, we look at herpes virus. The herpes simplex virus is in the zoster virus, and almost 9% of them were positive. Okay, and that's quite interesting. There was no association between reactivation and mechanical ventilation, but interesting, and like I said, the only time I've ever seen so much, zoster and HSV, and back in the old days when we had HIV and AIDS and people were getting sick in the hospital, their immune system were in their boots and they were getting reactivation of all sorts of latent viruses. And then similarly, when you looked at the trend was to have lower lymphocyte counts in those who had positive swabs. So I'll discuss the significance of that later. So which patients progress to long COVID? Anyone can, not just those hospitalized. You're just as likely with to have mild symptoms and develop long COVID. You're not significantly protected from COVID-19 vaccines. There is one study that says there's maybe a 9% less incidence of long COVID if you've been vaccinated, one American study. But as a rule, it's not just ICU patients who are really sick that get COVID. You can get it just from being in the community, getting a mild cold, a flu, and thinking you're going to recover. And then this is just a kind of summary of all the different symptoms that long COVID, get. And this is kind of the challenge because there's so many different manifestations. And the question is, what's causing these? Fatigue, muscle aches, shortness of breath, difficulty concentrating, inability to exercise, crashing, headache, sleep, anxiety, memory problems, dizziness, chest pain, cough, joint pain, heart palpitations, diarrhea, sore throat, night sweats, loss of smell and taste, tachycardia, fever, chills, hair loss. So lots of different symptoms. And unfortunately, what tends to happen, and we'll discuss this later, is if you have heart problems, you see a cardiologist. If you have, GI problems, you see a GI guy and they scope you. So people are being managed based on the organ that's affected and sent to many, many different specialists, rather than, linking up all these manifestations and looking at the root causes of these problems. Interestingly, a lot of you have had experience with Lyme disease. If you look at post-treatment chronic Lyme disease and you look at the symptoms of patients who are persistently infected with chronic Lyme, general constitution, fatigue, weight loss, rheumatological, arthritis, arthralgias, myalgias, neurological, cognitive, confusion, memory difficulties, disorientation, pain, headaches, cranial and peripheral neuropathy, tremors, a lot of similarities. And then, people say it's all in your head. I just saw 5 patients today with long COVID, and 2 of them had been sent to psychiatrists. And my experience with taking care of Lyme patients is half of them had been sent to psychiatrists because you're just crazy. It's all in your head. Well, it is all in your head. The CT scans are often normal. The PET scan, the MRI scans are often normal, but they've done studies on long COVID with PET scans. And if the posterior part of the brain, which controls your balance, which, controls your pain center, your respiratory center, the cranial nerves coming out of the brain, the sympathetic, parasympathetic, the vagus nerve, which is also involved, is involved. So so these PET scans showed hypometabolism, in posterior parts of the brain and sometimes in the cortex, and which were associated with the symptoms that patients were presenting with: the anosmia, the memory, the cognitive impairment, the pain, the insomnia. So when somebody tells you, it's all in your head, you're right, it's a PET scan. And unfortunately, you can't get a PET scan, but you don't need a PET scan. Research studies have shown it's there. It's a real entity. And then just comparing this to chronic Lyme, there's a condition called PTLDS, post-treatment Lyme disease syndrome. And these are people who got treated for Lyme and they're still not well, with all the symptoms I mentioned before, very similar to long COVID. And half of those patients are put in the psychiatric basket. But Hopkins and others have done studies using PET scans. And this particular study took 12 patients with PTLDS, that's post-treatment Lyme disease syndrome. You got treated for Lyme and you're still not well. And they had fatigue and memory change, difficulty with word finding, and they compared it to control. And they found hypoperfusion defects in the cerebellum, the frontal cortex, the parietal cortex, the thalamus, the temporal cortex, parts of the brain that are representing the signs and symptoms that people with long COVID with chronic Lyme are presenting with. So pathogenesis of long COVID, I'm not going to go into a lot of detail, but there's a number of publications now, and those publications go back to 2020. So we knew this, but at the end of 2020 and early 2021. So there seems to be some kind of immune dysregulation. There may be viral persistence in some situations. There seemed to be attack of the virus or attack of the viral proteins, which are contributing to these symptoms: fever, fatigue, brain fog, headache, neuropathy, sleep problems, loss of smell and taste, memory disturbance. So some kind of inflammatory, autoimmune, autonomic dysregulation that's causing these problems. And on the right, it kind of talks about the parts of the brains that are infected with this. So there seems to be some chronic neuroinflammation, neurodegeneration going on. So just because your CT is normal doesn't mean there isn't something going on in your brain. And this is one of the first publications that kind of hypothesize on what's going on with long COVID. And this details the mechanisms or the hypothesizes on the different potential factors. So potential contributors to these post-acute sequelae include damage to one or multiple organs, persistent reservoirs of COVID-19 in certain tissues, reactivation in neurotropic pathogens such as herpes virus under conditions of COVID-19 immune dysregulation. I mentioned that in the ICU group. COVID-19 interactions with the host microbiome, virome communities, clotting coagulation issues, and those microclots might actually explain the hyperperfusion of the brain. Dysfunction of the brainstem vagus nerve. So this is 2021, the vagus nerve, and we've known this for a long time. We're now approaching June 2023, and most people clinicians, GPs, are not aware of this. Ongoing activation of prime immune cells, autoimmunity due to molecular mimicry between pathogen and host proteins. And they summarize the individual nature of these symptoms suggest that different therapeutic approaches may be required to best manage care for specific patients with a diagnosis. Now, this is a very important study. It was published in the British Medical Journal, and it's Long COVID, an update for primary care. And it's published by a range of different people. From primary care to rehabilitation to informatics to respiratory medicine to somebody who was a professor emeritus who had COVID themselves. And then they go through a number of things, questions: why did I get long COVID and what caused it? And then their answers: symptoms, especially fatigue, may persist after many infectious illnesses, including other coronaviruses such as SARS and MERS, but no clear explanation exists why a particular individual develops long COVID while another recovers quickly. Long COVID is more common in those who had more severe acute disease, a trend towards that, but still can occur in mild or symptomatic disease, more common in people who are hospitalized, aged 30 to 59, female, living in deprived areas, working in healthcare, social care, education, with high BMIs, body mass index, and with more than one pre-existing activity limiting health conditions. So there may be something that predisposes you to get long COVID, but there's not one factor involved. The underlying cause of long COVID is not fully known, but several interacting mechanisms may contribute. A chronic low-grade inflammatory response is correlated with the severity of ongoing symptoms in patients who are hospitalized. Some patients in the hospital had evidence of multi-organ microvascular disease caused by immunothrombosis and endothelial dysfunction, and some show autoimmune response where the body starts to recognize its own tissue and organs as foreign. Some patients have COVID-induced neurological damage, particularly the autonomic nervous system, which controls involuntary functions, including heart rate. And I still see cardiologists doing cardiac ablation or putting people on beta blockers, which is the wrong strategy. Being chronically ill with unpredictable relapses may lead to loss of work, income, social interaction, which in turn can lead to poor mental health. Structural inequalities such as poverty, overcrowding, poor working conditions, inability to access services are important in the development and course of COVID-19 and may form an important context for long COVID. And what they do then is they go through some of the symptoms. and, investigations and management along COVID. So I'll just run through these quite quickly because I think it's quite important. And I won't talk really about the evaluations that need to be done, but just fatigue, low exercise intolerance, deconditioning. And this is described as your battery being flat, unable to do usual activities, trying to do more, worsens the symptoms. And people are still being told, push, 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 graded exercise. I had somebody today who was told to do that by one of the COVID centers, private COVID centers, and it doesn't help. That graded exercise has been debunked. You need to pace. So holistic management is key, self-management to function within available energy limits. Pacing is really the important strategy. Other symptoms, post-exertional symptoms, exacerbation. And then this is a situation where people crash and they relapse, and they get worsening of physical symptoms. So if they do too much physically, too much mental processing, looking at the computer too much, reading a book, too much stress, they crash. And then then their symptoms flare up. And I think then the critical component in all of this is learning to pace and not listening to people who tell you to push. Exertional breathlessness. I first thought, first wave of COVID, that the lungs would be damaged, permanently damaged, the hearts would be damaged, permanently damaged. But this exertional breathlessness, pulmonary doctors are doing pulmonary function tests, putting people on asthma medicines, which doesn't work. But this breathlessness, as a rule, is not bronchospasm related. So sometimes it is. COVID just can affect your immune system. People do get allergic symptoms. Some people with underlying asthma can get exacerbation. But very often, the breathing problem is not what I call a wheezing, a bronchospasm problem. It's more of a air hunger type problem. And then this is explained here, altered breathing pattern disorder. So people get diaphragmatic, paralysis, diaphragmatic damage. And then I mentioned to you that the PET scans show damage to the posterior part of the brain. That's where the respiratory center is. And there's two types of sleep apnea. There's a central sleep apnea and there's a peripheral. Peripheral is when people who are overweight have kind of, get obstructed in the larynx and pharynx. But there's a central sleep apnea, and skinny people or anybody. And I think a lot of the symptoms that people are getting are centrally controlled. And we need to you need to work on breathing exercises. You need to, rather than inhalers to fix that. Chest pain, people describe it as pain and exertion sometimes, but sometimes lung burning, something sitting in your chest. And of course, people think it could be a heart attack, and some people with high risk do have heart attacks. But very often, what is causing this pain? It seems to be some kind of inflammation, and many people think it's nerve inflammation, almost like a vagal nerve, because the vagus nerve runs through the chest and can contribute to that. And I've seen many patients on nerve blockers who actually got resolution of their chest pain with nerve blockers. And the recommendation is to use anti-inflammatories once other causes are excluded. But these anti-inflammatories also have their downsides. Some of the anti-inflammatories end up, causing ulcer and kidney problems as well. Throat and voice symptoms. People describe COVID strangle, sore and dry throat with a cessation of choking, altered voice, and people, go to the ENT doctors. They look into whether you've got esophageal reflux, but cranial nerve 1 and 2 causes smell and taste problems. But I've seen people with hoarseness, cough, yawning problems, tinnitus, ringing in the ears, facial nerve paralysis, and these are cranial nerve functions. So it's the cranial nerves running out of the brain that I think are causing many of these symptoms that patients are experiencing. Autonomic dysfunction, like I said, I think is critical. And people get this fight or flight phenomena. People get vagal nerve stimulation. And this is explaining a lot of the blood pressure going up and down, pulse going up and down, thermoregulation problems, heart, temperature instability. This is a sympathetic, parasympathetic issue. And the cardiologists are still, chasing, chasing other causes, doing cardiac ablations, putting people with pulses up to 170, running down to 35, doing multiple tests, saying all your tests are normal, you're just anxious. Anxiety doesn't cause this. This is autonomic dysfunction, and beta blockers will block your heart rate. But if your heart rate's already gone down to 35, the last thing in the world you want is a beta blocker to drop it even lower. And on top of that, a lot of these medicines have central problems. So you actually get a lot of collateral damage from some of these medications. Neurocognitive dysfunction, people describe brain fog, poor short-term memory, concentration, problem solving, executive function. It's really, brain fog is really a poor term. I think people have problems with executive function. There's cognitive problems. And you can, if you do studies, cognitive studies, you will actually see that. And how do you manage that? People get overwhelmed easy. So you need to pace. You need to pace, and you need, and there are some other interventions. And I use the analogy that if you get a head injury, you get a concussion from playing rugby, or GAA if you're in Ireland, or football if you're in Scotland, you get concussion, and you have a head injury, and you have brain fog, you have concentration problems, you sometimes have seizures, you sometimes have sleep disturbances, you often have mood changes, you have alcohol intolerance. There's a whole process that neuropsychologists, and neurorehabilitation specialists have developed to manage brain injuries. And I think we need to start looking at some of these strategies to manage these symptoms. Vertigo and dizziness, unpleasant episodes, room spinning. Well, if you look at the ear, there's a balance center in the ear. So there's a peripheral vertigo, and the nerves that run through the ear are the cranial. You've got cranial nerve 5 and 7 running through the ear, and they can be inflamed, and that can cause nausea. But you also have a central nausea. The posterior part of the brain, cerebellum, controls your balance. So there can be problems in both respects. So people can have a peripheral or a central caused dizziness. Loss of smell, classic, cranial nerve 1 and 2. It usually comes back, but not always. And then there are special recipes now for people who, to support people, so that they can have a better enjoyable taste and smell. I've actually seen people, recover their smell and taste from catching a second COVID or getting a COVID vaccine, interestingly. So it seems to be some kind of an immunological inflammatory process, but sometimes it doesn't come back. And as I said, we always focus on the smell and taste, but all the other cranial nerves are involved as well. I mentioned that lymphocytes can be affected, the lymphopenia, low lymphocytes. Well, lymphocytes, T helper cells, help control your immune system, as well as lymphocytes help fight infection, clear infection, and control your immune system. And people get histamine, mast cell problems. People get, I say the T helper cells are the conductors of the orchestra, and somebody just shot the conductor. So your immune system is just out of control. So people do get allergic-like symptoms, and these are rashes, some other symptoms, and sometimes you do need to use some antihistamines, H2 blockers, just to kind of assist with that process. So that is a component of treat. Poor sleep, and I think it's important to look at the guidelines here, what they recommend. Unrefreshing sleep, exhaustion, exacerbation of fatigue and brain fog, vivid dreams, nightmares. So there's inflammation, just like, as I mentioned, when people get head trauma, there's inflammation. When people get viral meningitis, they've got inflammation. So there's some kind of inflammation to the meninges. And in Ireland, I'm seeing people put on Dalmane, put on Zopiclone, and that's Zopsha. And then you're in coma for 2 days. You go to sleep, but it has collateral damage. And the guidelines here really say melatonin to restore the circadian rhythm. So I think we use melatonin in head trauma. We use melatonin in some certain behavioral disorders with children and young adults. And I think we need to use more melatonin because there's no collateral damage from melatonin as opposed to the other sleepers. But unfortunately, GPs are not getting guidance on what to do. Mental health, anxiety, depression, et cetera. And, and then people are being told they are psychiatric because they have brain inflammation. And sometimes you do need to go on an antidepressant just to make it through it. But the issue is that a lot of the antipsychotic medicines, the antidepressant medicines have a lot of collateral damage as well. But people do need some support. And people are devastated by being previously healthy, going for years and years to see one specialist after another, one test after another, and told there's nothing wrong. And like I said, 2 of the 5 patients I saw today, including 2 nurses, I mean, one of them a psychiatric nurse, was told by a long COVID clinic that, and one by a neurologist, that they were making up their illness and they needed to go see a psychiatrist. Not that they were having trouble coping with being unwell, but their symptoms didn't make any sense, therefore it must be psychiatric. Joint and muscle pain, and this pain migrates, very similar to Lyme disease. So it moves around, and then sometimes it's nerve pain as well. And what is causing that? The joints are not swelling, and it's transient, and it moves from place to place. And I would speculate that this is really also a central problem. Your brain centers in the posterior part of the brain, and that's triggering the pain peripherally. But sometimes people do need support, you know, and they have used amitriptyline, gabapentin, but most patients I know that go on that, their brain gets worse, even though their peripheral pain gets better. So I think you have to think twice about using these kind of agents. I had one nurse actually who had pain running through the chest. It was keeping her up all night, and the neurologist actually did a vagal nerve block. So, and the pain got better. And I have a few patients with these funny chest pains, and they went on gabapentin, and the chest pain went away. So there is an element of, you know, pain that's been triggered by the nerves. Patient accounts. This is also from this paper from British Medical Journal. I think this is in consultation with general practitioner. I think it was a really positive experience, and I felt really listened to. She was able to be honest at the point and said, I don't really know what I can do to help you, but you can phone me or email me at any point. And this is kind of the experience that people are getting, at least in Ireland, that there is no, they say that there's training for GPs, there's this, the GPs know what to do, there's referral patterns, there's not. And I think that's true many, many other places. We don't have a good joined up network. Another comment, my last interaction with my GP was in June. I asked about my lungs, and he said, what do you want me to do about it? You tell me. I have no idea. It was very dismissive. Nothing's got any evidence. So yes, sorry, I can't help. I went back to work after 5 weeks, still very well, because nobody believed in long COVID in May. They just didn't believe it. And I see this time after time, people now, a year after getting sick, no interventions, test after test, everything's fine, go back to work. And they go back to work. Nobody's very sympathetic, and they crash. You have to repair the damage before you put people back in the workplace. And the best analogy I can give is that you broke your leg, you're on crutches, you don't go out and run your marathon today. And if anybody tells you to go out and run a marathon, they're the mad one, not you. You need to repair the damage for 6 to 12 months before, and convalesce and you know, and repair and train before you're ready for your marathon. So I know a lot of people here in the UK, but I think across, you know, in the UK and across Europe, you know, that there's not really robust plans to manage long COVID. The UK plan was actually one of the first plans that came out, and it was really focused on pulmonary and cardiac. And they established centers, and this was based on the first wave. And the Irish actually did the same. They took what I think the UK guidance and just carbon copied it and put together a plan. And the plan was put together by pulmonary specialists. So they funded 9 pulmonary centers, 6 ID centers, and 1 neuro center. And I think what I've told you so far is the problem is neurology. It really should be asked backward. It should be mostly neurology centers and 1 or 2 ID and pulmonary centers. And in Ireland, they have a post-acute COVID clinic for the first 3 months, seeing patients with brain fog, tinnitus, and they're ordering pulmonary function tests for the brain fog. And guess what? It's not helping them. And recently I had somebody say, well, I went to the post-acute clinic, and they told me they didn't know what tinnitus was, and look it up on YouTube. So sorry about the spelling there. Still, you know, I see patients being told to get graded exercise. Graded exercise was debunked in 2018 by the NICE guidelines. Don't do it. You crash, it doesn't work. And I see many patients now still being told to do daily exercise, and they do it, and then all their symptoms flare up. They get some kind of a crash. And the issue is what's causing that crash. So an IC nurse out of work 2 years, tachycardia to 170, bradycardia to 35. She was told by the private cardiologist, they found all of the tests normal, you are just anxious. And I would ask MD in the room, check your pulse, see if you can make your pulse go up to 170 and down to 35. This is sympathetic, parasympathetic. Beta blockers are not the solution. And telling people there's nothing wrong with them, you're just anxious, is not the answer either. So a 9-year-old long COVID with, I just saw him recently, poor, dizzy, poor balance, and then subsequently seen by the ped neurologist who says there's nothing wrong with them, discharged him from the clinic and referred him to a psychiatrist. And this is the experience we had with Lyme for many years. And this is unfortunately the experience we're getting with long COVID now. Ambulance driver, infected on the job, out of work 2 years, unable to function, nothing done for him. Occupational health says, okay, go back to work. So he's working 1 day a week. He goes to work 12 hours a day, and he spends Tuesday and Wednesday in bed, crashing. And he covered, and he says, Dr. Lambert, I used to work 6 days a week. I used to take my dogs for a walk after work, in the hills, 5 hours, for 5 miles every evening. I can't do it. I'm getting fat. My dogs are getting fat. I said, I want to go back to work. I love my job. You can't force people to go back to work when they're still in crutches. You need to repair the damage. And as I said, there's lots of scientific data on the neurological complications of long COVID. And actually, I didn't know that when I set up the long COVID clinic in May of 2020, but the data started coming out in the end of 2020. Yang et al. Was one of the first articles I saw, 2021, talking about persistent brainstem dysfunction in long COVID. And that's when I kind of said, I think that's the answer. And a lot of the business plans and work I put together has been based on that study. And then there's subsequent studies from 2021 and early 2022 really focus on the neurology, neuropsych problems, et cetera, et cetera. And then, ta-da, here we are, Scientific America. This is just hot off the press, last 2 weeks, published in Neuroscience. Long COVID now looks like a neurological disease. And this should help doctors to focus on treatments. This is the headline of Scientific American. And this is American statistics. The causes of long COVID, which disables millions, may come together in the brain and the nervous system. And in America, affecting 16 million, with 2 to 4 million yet to return to work. And then the hypothesis, like we said before, several studies showing that COVID attacks the endothelial cells, the cells of the blood vessel that line the blood vessel. And I can tell you, when I was working in acute COVID in the ICU in the first wave, 10% of patients in the ICU were getting massive blood clots. And we're not seeing that anymore, but still, I think, it's a reasonable hypothesis that there's microclots, that are leading to oxygen deprivation in multiple organs, including the brain, and even subtle disruption of the endothelial cells in the brain could contribute to cognitive dysfunction. And this is just a slide that you don't need to read, but this is taken from the Scientific America. It talks about what's going on in the brain. It talks about maybe for a few months there's lingering virus. Maybe the virus doesn't disappear after 7 to 10 days, and then it leaves behind proteins, and then the immune system starts attacking those proteins, and then it starts attacking the blood vessels, and you get lack of perfusion. And this may be the explanation for these PET scans that you're seeing hypoperfusion deficits. So this is kind of my summary of what underlies long COVID manifestations. So it's not just one thing, it's lots of different things. There's deficiencies of zinc, selenium, magnesium, coenzyme Q. So it make, probiotics, interestingly, have been shown to speed up recovery from COVID-19. So your gut is your immune system, your blood immune system represents 10%, your gut immune system represents 90%. So repairing your gut, diet, probiotics, kefir, that's probably important. Inflammation and autoimmunity underlie many of the long COVID manifestations. Damage to the mitochondria with crashing is common. So people get this crashing and people think that's a mitochondrial dysfunction. There may be issues in microclots. Reactivation of other infections may contribute to ongoing fatigue if you get reactivation of the herpes viruses of zoster, of CMV, of Epstein-Barr virus. And then, as I said, besides brain inflammation and cranial nerve 1 and 2, you've got cranial nerve 10 and 11. And then the sympathetic, parasympathetic dysregulation, fight or flight, is common as well. So what happens? Multidisciplinary involvement. This is kind of a slide from the first wave. So in some situations, you do need pulmonary cardiovascular, you do need hematological, you need renal, but we really do need to have a plan for primary care to help. We need to have a plan for neurology and neuropsychiatry to support these patients. So what helps? CAMS, complementary alternative medicine, lifestyle counseling, diet, sleep, stress management, and then, as I said, interventions to target the brain and cranial nerves, neurorehabilitation, interventions to repair the immune system to stop this immune crashing. And I'll just summarize that here. Home exercises. This is an exercise that was actually put together by a patient that, or somebody that I've worked with, who kind of got themselves better. So the air hunger, they rebuilt the diaphragm, taught themselves how to breathe, principles of nasal breathing, and then you need to repair the sympathetic parasympathetic system, and nasal breathing can help that. And this is kind of a YouTube kind of demonstration on what you can do. So there is a role to rehabilitation of the sympathetic parasympathetic system. This is a publication that we did. We set up the long COVID clinic. I saw mostly staff members for the first year, and some of them just weren't getting better. And I've managed patients with chronic Lyme symptoms and managed them with low dose naltrexone. And I started actually just giving prescriptions for some of the staff and others, and did questionnaires on them at baseline and 2 months into starting treatment. So it wasn't really an efficacy trial. It wasn't a clinical trial. It was more kind of an observational study. But nonetheless, Brendan O'Kelly wrote this up, and we used naltrexone. What is naltrexone? Naloxone 50 milligrams is an antidote for people who overdose. But if you use it at lower doses, it has some kind of a unique anti-inflammatory and immune modulation effect. And it's been used by rheumatologists, by neurologists. I used it back in the day of HIV and AIDS before there was any treatments available. And it has some, like I said, immune modulation effect. So we actually, the questionnaire then on patients who were 333 days unwell, crashing every time they tried to go back to work. And within 2 months of starting the LDN, I feel I've recovered from COVID-19. How does my health limit my daily activities? In the past 4 weeks, do you have lots of energy? In the past 4 weeks, how's your mood? In the past 4 weeks, how's your pain? In the past 4 weeks, how's your concentration? How's your sleep? And actually, at every level, they were based on the Likert scale. There were improvements over 2 months. Now, it doesn't work for everybody, but we say there is no treatment for long COVID, and I think we have to look at other disease areas and see what works there and see if they'll work as well. And there are now placebo-controlled trials going on for LDN. In the meantime, I think we should be offering LDN. It's a very safe alternative. So this is a summary of the LDN study. It's safe. These patients who had been sick, young patients, ICU nurses and others, for 11 months, their symptoms improved at 2 months and statistically significant in 6 out of 7 parameters. Now, I've worked in Scotland with the herbalists because before antibiotics were available, we used herbs to treat infections. So I've used it for Lyme disease, and I've worked with Monica Wild, and there's a number of different herbs that, do have effects in, kind of supporting the immune system, et cetera, et cetera. And the Napier has put together a number of products. One of them is Sublime Vitality. And I always tell people you should be on Sublime Vitality. People are deficient in zinc, magnesium, selenium, coenzyme Q. In Ireland, they have Revive Active, Sublime Vitality, or just a multivitamin with coenzyme Q. And then Sublime Essential is a product that was put together also for Lyme patients, but it helps with cognitive, musculoskeletal, immune health, reducing histamine overreactivity, number of different ingredients, including NAC. And NAC is converted to glutathione. Glutathione is thought to be deficient in the mitochondria. So you're repairing the mitochondria, you're repairing the histamine, the mast cell issues. It's got curcumin, which is natural anti-inflammatory, And these are all kind of products that I've used before in Lyme patients and starting to use in long COVID patients. And I think it makes sense to do that. And this is just the information in N-acetylcysteine. I've used N-acetylcysteine for years, converted to glutathione, and there are studies showing, this is just one study showing that it, that it helps in a number of different disorders. It's helping them with mitochondrial disorders, including, and it's helping with Alzheimer's, ALS, autism. Interestingly, I saw one of the long COVID patients who works with the mitochondrial kids in Dublin. And these are kids who are born with mitochondrial deficiencies, and all these kids get NAC because they crash at any kind of exertion, and NAC seems to have a protective effect in the mitochondria. And I think that's part of the problem with COVID and long COVID, with the crashing. So management of long COVID, lessons from Lyme. Infections trigger a cascade of disseminated spread to multiple organs and tissues. There's a cascade of inflammatory and autoimmune processes. Microbe may cause damage at the mitochondrial cellular level. Patients are often lymphopenic with deranged lymphocyte markers. This causes reactivation of dormant DNA viruses. So management must address the issue of persistent infection, deranged immune system, immune crashing, neuroinflammation, and then critically, pacing, not pushing is required. Don't advise graded exercise. So this is just my suggested protocol: a multivitamin with coenzyme Q or Sublime Vitality, or some product, a probiotic or kefir, Sublime Essential capsules, or at least the NAC, N-acetylcysteine. And this all has to do with cost, because all these things cost and people are having to pay out of pocket. So all these things are expensive. But NAC 600 milligrams, 2 capsules a day. And then LDN you grade up to 1 milligram to 2 milligrams, 2 milligrams to 3, 3 to 4.5 over each dose over 2 to 4 weeks. And the patient I saw today went to see a cardiologist, believe it or not, 2 weeks ago, a private cardiologist, and they were put on LDN. Interesting. And then another patient I saw today went to the clinic in west part of the country and asked for LDN, and they said, no, we're not going to give LDN. There's no evidence it used, and Dr. Lambert is making money off LDN. So my God. Anyway, so there's lots of challenges, but I think there's no harm in using LDN, and it's worked in other conditions. And there's at least, a pilot that shows that it seems to be a benefit. For sleep disturbances, I think you should be using melatonin, and you can use more than 3 milligrams. You can use 10. For mood problems, sometimes people do need support, and I think you do need serotonin replacement. For allergic symptoms, an H2 blocker. And then retraining the vagal nerve. So people can do vagal nerve exercises. There is a transfollicular vagal nerve stimulator. And then for coagulation, there is this microclot problem. And in some cases, people, especially that get transient weakness and unilaterally, almost looks like a TIA, transient ischemic attack. I sometimes add a baby aspirin. We do that for people with many strokes. We use that for cardiac prophylaxis. And there's these products like nattokinase and lumbrokinase. And nattokinase seems to have some activity in that as well. Japanese use nattokinase as a herbal as a supplement, a food supplement from the day they're born, probably contribute to their longevity. And then there is a role of herbalists, nutritionists, and there's products like mangofero and creptolepsis, traditional Chinese medicine herbs, and then some of the magic medicinal mushrooms, they have CNS activity. And I think with time, we'll start seeing, benefit of these products as well. These are some of the publications we've done at Matter based on the work that we've done from the HRB grant, a total of actually now 19 publications. So what should the future look like in Ireland and the UK? There should be established multidisciplinary clinics that can support patients with long COVID, but not just long COVID, Lyme, CSF, ME, as they have similar pathogenesis and the PET scans look the same. So we really should, this is not a psychiatric condition, people should be supported. We need guidelines to support the GPs that in Ireland they say there's guidelines for GP, we're training them all, but they don't know what's going on and they're not told what to do and they don't have any referral patterns. And you shouldn't be prescribing medicines that just, put a Band-Aid on the problem because there's significant collateral damage. We need pathways to refer patients. GPs and occupational health have no way to refer patients, And private clinics in Ireland anyway are testing patients, testing, sending them to one consultant after another, cardiologist, neurologist, rheumatologist, dermatologist, etc. And at the end of it all, they're out a lot of money and not a lot of treatments are given. So my opinion is really the Irish government, and I think other governments should be supporting some of the treatments, at least, rather than making patients pay out of pocket. Low dose naltrexone, melatonin, N-acetylcysteine, hyperbaric oxygen has been shown to be beneficial in CSF. And I think we need to take on new science. It's the brain, not the heart and the lung. And the guidelines in the UK and Ireland really are still focused on the heart and the lungs and not the brain. And the post-acute clinics run by pulmonary specialists, the one at the Mater, they have a half-day clinic every other week. So there's a full-time consultant hired for post-acute clinic that's seeing patients with sleep apnea and almost no patients with long COVID because they don't need to be really seen by pulmonary doctors. In other countries' models of care, some have focused on the heart and lung, but there are some exceptions. And other countries are developing neuro rehab models, and the USA is coming on board. UCLA, other centers are the ones that were really involved in the Scientific American publication. So I just want to mention for the people from Ireland that we did put together a matter business plan back in 2021 based on this, and then we submitted it again. We were not funded to continue our clinic, and unfortunately we had to close down our clinic, but we actually submitted in July of 2022 a multidisciplinary clinic at the Mater, serving both North Dublin, our inner city population and beyond. And we requested one full-time neurorehabilitation consultant, an ID consultant, a half-time neurology consultant, a psychologist, physiotherapist, occupational therapist, a clinical nurse specialist, a GPA liaison, a community nurse, and also they would work with the funded pulmonary consultant, and we would be running 3 clinics, who are there right now. The pulmonary guys are running 3 clinics twice a month, seeing almost 0 long COVID patients. Our plan was to run 3 clinics a week, providing appointments for 60 to 80 patients a week, which would be 3,300 a year, to maximize outpatient management by virtual consultations, which would support another 3,300 a year, liaise with GPs, provide training for GPs, so that patients could be managed locally in consultation with the center. And this was all put together in 2022. And, unfortunately, we weren't funded and we've had to close down the clinic. And I'm only seeing patients privately in Dublin. And actually now I'm seeing them in Edinburgh, and people can make appointments if need be or get advice from me in that way. But I'm still optimistic that we can get going again. But just to comment then, there's politics in all of this. And why did the Irish HSC and the Minister of Health, Donnelly, not fund the Mater Hospital, which was focused on neurorehabilitation and GP training collaboration? And this is actually the reasons given in a letter sent by Stephen Donnelly to one of the ministers who'd requested. And they basically said that HICWA, which is the Irish kind of health assessment, a quote from their summary: most guidelines are recommending a holistic, person-centered approach to diagnosis, management, and treatment with emphasis on shared decision-making, which is consistent with the HSC's interim model of care. So the HSCR content of the interim model of care is in line with the international best practice and will continue to review the interim model as new evidence emerges. And I would propose that the new evidence was available 2 years. They're missing it. So the HSC has reviewed the Mater business case. This is what the letter says. So they've internally communicated with other departments of the HSC, but not to the Mater, that the business case would have required alignment with the HSC or interim model of care prior to recommending for funding. So no direct communication has, but my reading of that is that since, I'm critical of that we don't need pulmonary and infectious disease specialists, we need neurorehabilitation specialists. This is really, unfortunately, the reason that that we haven't been funded. But interestingly, if you look at the HICWA conclusions that the HSC have used to defend their support, 𝐃𝐈� concludes in their review, in terms of service planning, the included guidance and our models of care highlighted the need for a focus on continuation and coordination of care for individuals with long COVID. This should be facilitated through a comprehensive multidisciplinary service that includes core team members such as physicians with relative experience and specialists in allied health, clinical psychology, neurology, pharmacy, and rehabilitation medicine. And I would just propose that this is the matter business plan that according to the HSC is not in line with the interim model of care, that it is in line with the 𝐃𝐈𝐒 conclusions. So final slide, just end on a humorous note. The emperor has no clothes. COVID acts fast. Many of the plans in Europe for long COVID are way behind the times, way behind the science. And I don't think we should be defending our mistakes. We should be changing course. We should be listening to patients, which has not been done in Ireland, and I'm not sure it's been done elsewhere. We need to take on new science, and the government and the people who are making decisions and funding and supporting, providing money, need to come up with a new plan that keeps pace with the new science. So I'll stop now and leave time for questions. Thank you.
Thank you very, very much, Professor Lambert. That was absolutely stunning. You packed so much into that, and we've got so many questions. We're never going to cover them, but we can talk about that in a moment. So I'll just ask a couple that we received beforehand, because some were sent in. Does long COVID do something to the ligaments in the neck or a vascular issue? This person, I think, has head pressure, swollen pain, flares in that area. And they're wondering whether Lyme disease could have something to do with it too.
Right. Well, first off, I think there's neuroinflammation. And like I said, I think that is really the critical component. And even though there's pain in the neck, it moves to a different location. So it can't be permanent. It's not like an injury, like you get a bruise or something like that. These pains that people are getting are migratory pains. So I think they're really very much centrally triggered. So I think they're neuropathic pains and they're inflammatory changes, and they're sometimes in the nerves, they're sometimes in the muscle, they're sometimes in the joint. Yeah, I think they are. I mean, all of those are possibilities.
Yes, and have parasite infections been shown to coexist with long COVID?
Well, not exactly, but like I said, I mean, COVID causes immunosuppression, and you're getting reactivation of viruses, and that's the population of people who are more prone to get, to acquire, pathogens that otherwise wouldn't cause you problems. If you look at people with HIV and AIDS, as they get sicker with HIV and AIDS, they get all these intestinal parasites, they get schistosomiasis, they get all these parasites and stuff, but when their immune system's high, they don't have them. So I'm not disagreeing. People are more prone to catch some otherwise innocuous infections or get reactivation of infections that they were coexisting with. But the critical component is, if you repair the immune system, they'll be flushed out, and they'll manage themselves. So I don't really focus on parasites. I focus on the immune system as the trigger for reactivation of all these conditions.
Thank you. Given that some cases of long COVID that you described seem to be due to reactivation of latent viruses, and that many of these are herpes viruses, would you consider standard antiviral treatments such as acyclovir?
Right. Well, the thing is I see patients all the time. So I saw a 33-year-old with 3 episodes of zoster in 6 months, excruciating pain. And, he's incapacitated with it. So the solution is not to treat the zoster, but as a temporizing solution, like when I see people with recurrent shingles, I put them on acyclovir, or I put them on, actually Valtrex is a better choice because it's once daily. I put them on 500 to 1,000 milligrams of Valtrex to suppress the shingles so they don't ongoing reactivation while you repair the immune system. So, but these antivirals work for herpes simplex, they work for zoster, but they don't work for Epstein-Barr, they don't work for CMV. But there is a role for antivirals temporarily as part of the solution, short-term solution.
Thank you. One patient here is asking, she made a 75% recovery from Lyme, but now has had long COVID for 1 year. Do you advise in cases like that that they revisit treating Lyme?
Yeah. Well, the thing is that Lyme can be cured, but in some situations, I think when people get treated for Lyme, the bacteria just actually is 99% killed off, but not 100%. And then if another hit comes along, it can be reactivated. So I think the symptoms are very similar. I saw a young child recently, and he got long COVID, and all of a sudden he broke out with all these stretch marks on his back and he's skinny. And I think he might have Bartonella. I think he might have had Bartonella before that was just latent. And now he's reactivated, not just, the COVID, but the COVID has reactivated Bartonella that was just kind of subclinical. So I do think you have to readdress the fact, have you been cured of Lyme disease when you get long COVID? Because your symptoms might be just long COVID, but there might be a role for retreatment of the Lyme disease.
Yeah, thank you. There are a lot of questions expressing frustration here, partially answered by you anyway, like, why doesn't NICE accept these brilliant publications that you've gone through? One very specific question here was, when can we expect some form of testing with biomarkers? It would really help to counter the tendency of some to see long COVID as simply psychosomatic.
Yeah. I mean, the trouble is, you should see, I've explained to you, it's complex. It's, there's so many organs involved. Sometimes it's a microclots playing a role. Sometimes it's an immune, autoimmune process. Sometimes it's a lymphopenia is playing a role. I don't think we're going to be able to find one magic biomarker. It's not that easy, but you're right. People with long COVID are running into exactly the same problem as chronic Lyme. I had somebody recently who had, went to the long COVID clinic. He's all the symptoms of long COVID plus pains all over, and then the letter I got was, this is not long COVID. This is fibromyalgia. It's like, Jesus, fibromyalgia is not a diagnosis. It's a description of a set of symptoms. I hurt all over. And she didn't hurt all over before she got long COVID. So now they're saying she doesn't have long COVID. She's got fibromyalgia. You're right. Having a magic diagnostic tool would be helpful, but we don't. And unfortunately, we have so many clinicians who don't want to take care of patients with chronic fatigue. I think that's what we're running into. And they're so willing to put them into the psychiatric basket and discount all the science that I've presented today. It's real. There's something up in the brain. There's all these studies showing microclots, showing autoimmune processes going on. And I hope, like I said, I hope there's so many publications, so much work and money being put into long COVID that it will not just benefit long COVID, but will benefit the chronic Lyme and the ME communities as well.
Absolutely. Thank you. You mentioned alcohol intolerance towards the later part of the talk, but earlier you said that you found a lot of the patients seem to be using alcohol in order to perhaps quell their symptoms.
But those are not mutually exclusive. I mean, the thing is that my patients that get long COVID or even chronic Lyme or head injury say, I used to go out with my mates to the pub and drink 10 Guinness and have a great time. Now I go out and 1 Guinness. I'm a lightweight and it's the same effect as 10. So I didn't say people are using more quantities of alcohol. I'm saying that some people are turning to alcohol that weren't turning to alcohol before as a way of relieving their symptoms. So it's not like they're drinking huge quantities, but it's just the fact that they're using it and they weren't using it before.
Thank you. Going back to your cohort at the Mater, a question here. I'd be interested to know whether any of the cohort tested for Lyme and co-infections and what the results were.
Well, the thing is that we actually, we don't have the resources to test all of those, but just incidentally, I mean, I've been doing, antibodies, EBV and CMV antibodies. And I've actually seen, unfortunately, these antibodies you need PCRs. You can't do PCRs in outpatient. It's really limited in terms of what you can do. But I actually have seen quite a few people acquire CMV and acquire Epstein-Barr virus, post-COVID. So I think, you're more susceptible to even catching some of these infections. So there is the issue of reactivation that's hard to prove in the outpatient because we can't do PCRs. It's a test that's limited to the hospital inpatient setting. But I can tell you anecdotally, I think people are immunocompromised and they are getting some patients, it's hitting their immune system and they're catching all these infections, including Epstein-Barr virus, CMV, that they never had before. And that may be contributing to some of their symptoms.
Absolutely. Thank you. Yes, we've had Dr. Schwarzbach talking about that with a lot of scientific papers to back it up as well. Another question here. Are there studies of a combined cohort of long COVID and CFS-ME patients being conducted now, or is it really just long COVID?
Well, it's just long COVID, I mean, some of the patients, like I said, some of the patients who had CSF, chronic fatigue syndrome, ME, or some pre-existing condition. I have patients like maybe 10 years ago had Guillain-Barré, or 10 years ago were in hospital with Epstein-Barr virus. They're coming in, I think they seem to be hit worse by, or maybe be more prone to get long COVID,
Right, yeah. What are nerve blocking medications being used or tried for treating COVID? Would low dose naltrexone fall into that category, or are there others as well?
Well, I think LDN is one of the safest, anti-inflammatories, and it decreases inflammation in the brain, it decreases inflammation in the nerves, it decreases inflammation in the joints. I mean, I see patients being put on amitriptyline, pregabalin. I mean, I prescribe those as well. And sometimes sometimes they are helping people, but at the cost of, the brain. The brain is worse. They have central effects, just like I said, even, all of these medications have central effects. So they are blocking, maybe helping with the peripheral nerve pain. But, that it's not a sustainable solution, and it's helping the peripheral nerve pain, but it's worsening the brain fog.
Thank you. Yes. Have you found or heard that Paxlovid could be helpful in long COVID? It is being used in the States in certain situations.
No, not that I'm aware of. I mean, I just think that just only in the acute setting, I mean, it's an antiviral. I mean, you'd have to make the argument that there's persistent infection beyond 14 days, that would be the value. And there is hypothesis is that even though the virus is gone from the bloodstream and from the nasal secretions and the pulmonary secretions, there may be a few months where it's still present in the brain, and that may be contributing to the long COVID symptomatology. And there's been publications showing viable virus, but so you could make an argument that theoretically an antiviral would have effect, but it's still not being, research is ongoing whether that is a real phenomena, ongoing persistent virus, as opposed to dead virus and autoimmunity with molecular mimicry, the virus attacking, the dead proteins, that is, so we're still on, I'm still on the fence in terms of that.
Right. Because you did mention POTS and autonomic conditions, how do you suggest managing POTS if beta blockers have unwanted central effects and the other medications that you mentioned?
Well, there's another drug called ivabirine, which is a cardiac drug that is used for heart failure, and it has effect on the conduction system, the calcium, the channel block. It's a channel blocker as opposed to a beta blocker, because the risk of the beta blockers is actually going to, slow your heart down even faster. And if you're having heart rates of 170 down to 35, that's great to not a beta blocker keep you down at 100. But what if it takes you down to 20? So there are some alternative agents, but I would also say that this is a sympathetic parasympathetic issue, and I think actually some of the breathing reconditioning, some of the alternative methods are probably safer methods to use, but there are other agents that can be used to block the heart. And then POTS is I mean I have people who say, well, I think you've got POTS, but their heart's gone up to 170 and down to 35, but their blood pressure's gone up to 170 and down to 90. So that really isn't POTS. POTS is hypotension, you know, so it's not as simple as POTS. And you know, people give IV fluids, people give mitidrine, which is a medication that causes you to hold on to sodium, and then you retain more water and your blood pressure stays up. But I don't think you can just apply the same strategy to POTS as, you know, COVID-induced kind of sympathetic, parasympathetic dysfunction.
Oh, thank you. So many questions. I think we're going to have you back, Professor Lambert, to just do questions. We've never had so many. I mean, we have over 100 here. Many very, very different topics. You can't say that they all fall into one category. Are fungal infections common after long COVID, in your opinion, or does that fall into the same condition as parasites, i.e. it's the low immunity?
I think it's the same. I think it's the same. So somebody just corrected me. Mitidrine is an alpha-2 agonist. So, so I misquoted. It's more of what it does, but it you know, it has some of the same things. But the issue is that in acute COVID we were seeing unusual mucor, you know, fungal infections and mold infections. That hasn't seemed to be a problem. You know, I think if, you know, you would see more mucocutaneous candidiasis, you'd see more infections in long COVID. I haven't seen that. But similarly, I think if you did, I think it's the same strategy, is that, you know, why do people with AIDS have more candidiasis? It's because their immune system is low. When you get the lymphocytes working again, they don't get candidiasis anymore, you know. So I think repairing the immune system is the critical component. But I haven't seen fungal infections reported in long COVID.
Fantastic. Thank you so much. I think we'll probably have to gradually draw to a close now. We're saving all of the questions, and I'm hoping very much that we can encourage, you know, sort of entice.
If you send all the questions to me, I can actually individually answer them by typing, and then you can circulate them. Okay. Oh,
that would be amazing. Okay. Thank you very, very much. And just to say how many accolades there are here. People just so grateful to you, amazed at everything you've done for patients and are doing. And also a lot of unhappiness at the, you know, political issues that you've described, particularly in Ireland, but I think all over the world, actually, not just.
Yeah, it's not. I'm using Irish as an example, but politics were a big part of acute COVID with the lockdown, and now they're becoming a big part of the long COVID, unfortunately. And the patients, especially the disadvantaged patients, are the ones that are suffering.
Tragic, absolutely tragic. Yes, I mean, we've got participants from all over the world here, and people are writing in that in their countries it's very, very similar. So thank you so much again. And I dare not send you the 100 and more questions, so we'll try and work out a solution for that. But just fantastic. You can see how many votes of thanks are coming in here. We do have another webinar in just a few weeks with Professor Shimazaki from Moleculera in Oklahoma, talking about how strep A and scarlet fever, which have reactivated so recently amongst children particularly, are contributing to the PANS-PANDAS type symptomology, which we haven't gone into here, Professor Lambert, but I'm quite sure with all your emphasis on the neuro dysregulation is really part of the same syndrome, and of course the autoimmunity. So of course we'll warmly invite you to that too.
Right. So and you're welcome. And you're welcome. My slide presentation, I mean, it's you're welcome to distribute it to anybody that wants it. It's not they're not copyrighted. So
oh, thank you so much. Yes, we have had questions.
People want to share them and you know, give them to other people that couldn't attend today. They're welcome to do that.
Brilliant, thank you. And many have asked whether the recording will be made available. Absolutely, it'll be put under our past webinars section on the website within just a few days. So thank you very, very much again. And thank you to everyone who's been here watching, and to everybody who does watch it in the future. And hopefully we'll see some movement, particularly in the interaction between the long COVID therapies that are beginning to emerge and ME, CFS and long Lyme. Yeah, I mean,
Right.
just hope. Thank you very, very much. Bye-bye.
Bye now. Bye-bye.